parietal lobe is bounded by sulci and fissures. Anteriorly, there is the central sulcus. Posteriorly, there is the parieto-occipital sulcus. And inferiorly, there is the sylvian fissure. The primary somatosensory cortex and association regions, Brodmann's area 5 and 7, are located on the lateral surface of the parietal lobe. Take a look at the sensory homunculus, similar to the motor homunculus which we saw in a previous lesson. It is a graphical representation of the sensory function of the tissue sitting below it on the primary sensory cortex. Compare both homunculi. Note the large representation of the face and tongue near the hand of both the motor and sensory homunculus. On a clinical note, in complex migraine, seizure, and stroke, this proximity commonly leads to the presence of motor and sensory symptoms in both the face and hand simultaneously. Let's now look at some clinical anatomical correlations in the parietal lobe. The parietal lobe controls sensation. There are cutaneous sensations which are appreciated here. These include pinprick, light touch, vibration, proprioception, and temperature appreciation. Also accommodated in the parietal lobe are what are known as cortical sensory modalities. These include two-point discrimination, the ability to determine two separate touch points, graphesthesia, the ability to determine the identity of numbers written in the palm or on the fingertips, stereoagnosis, the ability to determine an object's identity by touch, double simultaneously presented sensation appreciation. This can be either tactile or visual. And somatosagnosia, the ability to recognize yourself. Damage to the parietal lobes can lead to the inability to perceive multiple stimuli of the same type, either tactile or visual, simultaneously, a process which is known as extinction. Neglect, the failure to perceive items on one side of the body, can also occur as a result of unilateral parietal lobe damage. The drawings of visually presented stimuli containing missing pieces from the side affected with neglect is illustrated here. Optic radiations pass through the parietal lobe, carrying information from the inferior visual fields. Dorsal optic radiations contain fibers from the superior retina and, when damaged, cause an inferior quadrant field loss or inferior quadrant anopsia. This commonly results from stroke, masses, and inflammatory lesions in the parietal lobe. Generally, all strokes involving the parietal lobe will produce agraphesthesia, loss of two-point discrimination, astereoagnosis, and extinction. Parietal damage in the dominant hemisphere can produce what is known as the Gerstmann syndrome. This involves 4 distinct symptoms. Right-left confusion, where the patient is unable to distinguish between the right and left sides of their own body. Finger agnosia, where the patient cannot name or differentiate their digits. Acalculia, inability to perform simple math. And agraphia, inability to communicate in writing. Other symptoms of parietal stroke include asomatosagnosia, the loss of recognition or awareness of a particular body part, dressing apraxia, where the patient cannot dress properly, constructional apraxia, the inability to draw or copy diagrams, and geographic disorientation, the inability to form a conceptual map of a region or area.